Assalamualaikum doctors. In this video, I'm discussing a common video station coming now, that is about lymphadenitis, cervical lymphadenitis. So first of all, opening statement is that school age child with fever and swelling in the neck. And DD, we are telling the neck swelling DD. These are lateral neck swelling DD, acute unilateral, acute bilateral, subacute and chronic. So acute unilateral are like reactive upper respiratory tract infections, Streptococcus pneumonia, skin infection or group B Streptococcus, Staphylococcus aureus, dental infection and anaerobes, Kawasaki disease, cat scratch disease and the Kikuchi Fujimoto disease. So these are acute unilateral, reactive, Kawasaki, cat scratch. What about acute bilateral? These are reactive viral upper respiratory tract infection, Epstein-Barr virus, cytomegalovirus, that is generalized lymphadenopathy and hepatosplenomegaly. So Epstein-Barr virus infectious mononucleosis, sometimes they ask take viva from this lymphadenopathy. Then subacute are non-tuberculous mycobacterium infections, mycobacterium tuberculosis and toxoplasma gondii. So tuberculosis also they take. And then chronic are reactive neoplasia, lymphoma, leukemia, soft tissue tumors and systemic onset of GI and SLE. Lymphoma viva also they take. So what history we ask in a lymphadenitis patients? First of all, onset, course and duration, what increase or what decrease. Any fever, any weight loss affecting his activity. Any neck deviation or torticollis, shape of the head, any discharge from the swelling, any skin redness, is it painful or not, any contact with the cat or scratches in the arm, any other lymph node swelling in any part of the body, any rashes in the body, bruises, bleeding from the body orifices and history of the trauma, any cough, shortness of breath, chest pain, night sweating, night fever, vaccination status, especially the BCG vaccine, any dysmorphic features, any other family members with similar conditions and history of travel recently. So I understand onset, course and duration, fever, weight, activity, sleep, then neck deviation or torticollis, space, shape of the head, any discharge from the swelling, any skin redness, is it painful or not, any contact with the cat scratches in the arm, any other lymph node swelling in any parts of the body, any rashes in the body, bruises, bleeding from body orifices, history of any trauma, any cough, shortness of breath, chest pain, night sweating, night fever, vaccination status, especially the BCG vaccine, any dysmorphic features, any other family members with the similar condition and history of travel recently. Then what examination I will do in this patient, cervical lymphadenitis. ABC vitals, hydration status, very important. Shrunken eyes, urine amount in the diaper, skin turgor, entry fontanelle. General examination for all lymph nodes group, axilla, supraclavicular, suprasternal and groin. For other nodes, skin examination over the swelling for signs of inflammation. Skin examination for any cat scratches and BCG scar. Abdominal examination for hepatosplenomegaly, testicular examination for exclude malignancy, ENT examination for the throat and the tonsil disease. Now what about the management plan? Investigation, urgent investigation if any one of the following noted. Lymph nodes are when we do the urgent investigation. If lymph nodes number 1 supraclavicular or suprasternal, diagnostic or significant pathology. More than 2 centimeter at 4 to 6 weeks, growing is more than or equal to 2 weeks, not return to baseline, less than 1 centimeter at 8 to 12 weeks. Signs and symptoms are petechiae, purpura, respiratory compromise, dysphagia, hepatosplenomegaly also need to be excluded, Epstein-Barr virus, weight loss and night sweat, tuberculosis, malignancy, early investigations and persistent fever more than 2 weeks. So we understand when we go treatment plan. First of all, if supraclavicular, suprasternal, diagnostic significant pathology, more than 2 centimeter, 4 to 6 weeks, it is growing more than 2 weeks and not recurring to the baseline, less than 1 centimeter at 8 to 12 weeks. Then there is petechiae, purpura, respiratory compromise, dysphagia, hepatosplenomegaly also need to exclude, Epstein-Barr virus, weight loss and night sweat, tuberculosis, malignancy and early investigations, persistent fever more than 2 weeks. Lab, what we do, full blood count, blood film, ESR, CRP, LDH, liver function test. Full blood count, blood film, ESR, CRP, LDH, liver function test only if suspected viral infections. Serology for toxoplasma, cytomegalovirus and Epstein-Barr virus culture and sensitivity from the discharge if present and blood and culture sensitivity. Imaging, we do the chest X-ray, we find hilar lymphadenopathy on the chest X-ray, refer for biopsy to the suitable node. Hilar lymphadenopathy significantly increases likelihood of the neoplastic disease. Ultrasound scan is in acute lymphadenitis, high sensitivity and specificity for abscess formations. In chronic lymphadenopathy for assessing the size, architecture and vascularity. CT only if suspected deep neck space infections. Okay, discuss with the ENT for biopsy in certain situations. Number 1, atypical mycobacterial infections and feature of highly suggestive of neoplasia. When we understand it is going neoplasia, lymph node is more than 2 cm in diameter, all supraclavicular and suprasternal nodes. Constitutional symptoms like weight loss, fever, loss of appetite. These are hepatosplenomegaly because of Epstein-Barr virus and generalized lymphadenopathy. Treatment I am telling. First of all, systemically well and node is less than 2 cm, no treatment, GP follow-up in 2 weeks. Remember, less than 2 cm, no systemically child is well, no treatment, GP follow-up in 2 weeks. If acute, co-amoxiclav oral for 48 hours. If improved, continue for 10 days. If chronic, more than 6 weeks, co-amoxiclav for 2 weeks, still result of investigations is appears. Atypical mycobacterium ENT referral for surgical excision. So we understand that no treatment if less than 2 cm and systemically well. GP follow-up only 2 weeks. And if acute, co-amoxiclav oral 48 hours. If improved, continue 10 days. If chronic, more than 6 weeks, then co-amoxiclav for 2 weeks, still result of investigation appear. Okay, so treatment is co-amoxiclav if more than 2 weeks, and investigation we do. And atypical mycobacterium ENT referral for surgical excision. Thank you.